Hi, I'm rather excited to be here at the launch of this best practice statement, and thanks for Activa for making this all possible. As a vascular nurse specialist, I am so glad that leg ulceration is back on the main stage in Harrogate. Hallelujah, we're going away from pressure and ulceration and pressure prevention, because to me I felt like there's a massive elephant in the room that we've been choosing to ignore for years, and to me now it's about bringing it really to the heart of what we can be doing to get these patients healed quicker. So let's just recap where we are. The published evidence from the research trials and the AQP documentation tells us that 70% of venous ulceration should heal within 12 to 16 weeks. And 98% of all venous leg ulceration should heal within a 24-week time frame. Well, in my practice, it certainly doesn't feel like that. And the best outcome of prevalence of what we've got currently is the paper by Julian Guest and Kath Bowden. They've told us that healing rates in their study, when they looked at, it was only 9% at 6 months, with a mean time to healing of 5.1. How are things so different in terms of what the evidence tells us and what the reality really is? And if you looked at the healing rates from the Julian Guest paper in more detail, only 40% of venous leg ulcers healed within the 1 year period of their study. And most interestingly and rather shameful for me, when you look at this, if you see the amount of unspecified leg ulcers that's there, they managed to heal the same amount of unspecified leg ulcers as what venous leg ulcers. How come we've got so many unspecified venous leg ulcerations? How can we reduce this unwanted variation in practice? So, why so bad? Well, I see the answers every day in clinical practice. Ulceration is not treated as an ulcer, it's treated as a wound in the lower leg. ABPI measurements are not performed. There's problems in equipment, time, competency. There is the problems with interpretation of ABPI. Subtherapeutic compression is out there everywhere, and we know we have problems in inadequate compression techniques, and we all see bandages like this, unfortunately, in every day of our practice. And I appreciate some of the reasonings behind this. I know that there is a problem with nursing resource. Goodness gracious, we've all seen changes in nursing over the last few years, but more so than ever before in adult community nursing services. And we know that there is a problem in nurses' access and education, and we know that our patients are getting older and fatter. But we're spending £5.3 billion on wound care, and if you went to Julian Guest's lecture yesterday, he told us these figures are going to raise year on year. We don't have unlimited resources. We have to do things better. We have to do things smarter. We have to heal these patients if we possibly can. Now, in terms of evidence-based, I'm a researcher, so evidence is the heart of everything that I do. There's hardly any evidence, truthfully, in the terms of wound care, apart from when it comes to compression. There's loads of evidence out there. We know that there's great RCTs out there, there's systematic reviews, there's guidance from NICE of what we should be doing. There's a fantastic research done by Rebecca Ashby and her team up at York University, telling us that compression hosiery kits heal as well as compression bandaging. And we all have felt the power of compression within our hands. We know the difference it can make to our patients. But this is a slide that I went to a recent presentation by the National Institute of Health Research, and I think this slide really summarises where we are at this moment in time. They say there's a lack of evidence-based care, a lack of diagnosis. Treatment is differentiated from what we know is proven to be best. There is lack of Doppler assessment. We know that there's a shift in healthcare provision. There's this great debate of whose patient is it? Is it the practice nurse's responsibility? Is it the community nurse's responsibility? And we do know that we haven't had senior management engagement. I do think that may be changing. And we do know that there is an inconsistency certainly in the compression selection. So, to aid and help solve a lot of these issues, Wounds UK have published this most up-to-date best practice statement, which underpins the best practice, challenges some of the myths, and additionally it provides a clear pathway of how leg ulceration should be managed. And within the pathway that's included within the best practice statement is a generic pathway. It's not product specific whatsoever, but we've adapted this practice within Mid-Yorks and made it very product specific. And I'd just like to share with you our experience of using this to try to improve our patient outcomes. So let me talk you through the algorithm. Well, It starts with a wound in the lower limb. And we know that there are 730,000 patients out there with leg ulceration. And we know that we need to improve the recognition, and we've purposely left out the word ulceration within that. We're not bothered whether you want to classify it as an ulcer or not. We're interested in if it's a wound on the lower limb. If it is a wound on the lower limb, we want you to try to classify the diagnosis of the underlying disease pathology, which may have caused that wound or may be hindering that healing. And it focuses that practitioner to really make a specific diagnosis in terms of what is causing that ulcer, because we also know that 54% of patients out there have got unspecified leg ulceration. It also asks the practitioners to consider what alternative diagnosis may be. If there isn't any signs of venous disease, what else could it be? What other tricks may they be missing, and how patients should be signposted? And then the pathway goes to ensuring that the ABPI is the heart of what we do. It clearly signposts that the ABPI should be performed, and it tells them what we should be doing, and it helps to challenge the myth that if the ABPI is not within that normal range, compression can be used, but that needs to be a decision by a specialist with probably some further investigations, but it certainly can be useful for other groups of patients. But hopefully this, by putting the ABPI in the heart of this will ensure that we've got a reduction in that variation of practice, because 84% of patients with leg ulceration didn't have an ABPI assessment. And to me, that's shocking. So, in terms of the first part of the algorithm, there's nothing new. I'm sure it doesn't surprise any of you out there, but it just embeds and reminds the practitioners out there of what good practice should look like. But where I think the algorithm has absolutely magic is the selection of compression. I think we often forget as a specialist audience here of how challenging it is for the generalist nurses out in community to pick the best option in terms of compression. We are close to the evidence, we are close to the new products that's coming out there, but there's such a wide variation now in compression options. How can the generalist choose those? And this algorithm helps to make those difficult decisions. It embeds putting compression hosiery kits first line. We know that that will help with self-care, it will help reduce the costings. We know that they're as good as compression bandaging. We know that that gives a sustained compression that's not practitioner dependent. We should be using those more and more. So in terms of the compression selection, it's basically down to two main components. The first component is whether the exudate is controlled within the dressing. The second component is whether there is any major limb distortion or elements of edema. If the exudate is not controlled within the dressing, that patient does require compression bandaging. And if that patient has got an element of edema, we recommend the patient is placed in Actico 2C bandaging to help target that edema management, reduce that limb volume, and hopefully promote healing. If that patient has got a venous leg ulcer though, and the exudate is not controlled within the dressing, we advocate the use of Aspen and a flex elastic bandage system. But we're asking the nurses out there to reassess the wound on a weekly basis, and as soon as the exudate is reduced, we want them to consider going further down the algorithm. But we're asking them also to focus on why is the exudate so high? Is there other things out there? Is there problems in terms of colonisation, biofilms? Could we be using a better dressing that's going to manage the exudate better? And you can see that the pathway links back round, so we're asking them to reassess on each and every change. But if the exudate is controlled within the dressing, the next question we're asking them is there any larger reducible edema or limb distortion? If there isn't, if it's a classic venous leg ulcer with no edema, those patients should be managed in an Activa leg ulcer kit. If there is evidence of edema, we need to concentrate on that edema. We need to reduce that volume of that leg. And to do that, we should be placing them in Actico bandages. And in time, once we get that edema under control, that patient should be stepped down in the form of an Actilymph hosiery kit. But the algorithm also importance the real issue in terms of prevention of recurrence. We spend so much money in healing these patients and hardly any money whatsoever in keeping them healed. It links to the best practice statements in terms of compression hosiery, but also it embeds the fact that these patients should be referred to a vascular centre for assessment of their venous insufficiency, because we know that if we intervene on patients with venous insufficiency, we can reduce the chances of recurrence of ulceration by 2/3. Why aren't we offering more patients that simple day case surgery? But it also states that if there is no improvement in that first 4 weeks, these patients should be referred up to the specialist teams earlier, because we know the quicker we get these patients onto advanced treatment programs for this hard-to-heal group, the better we've got in terms of outcomes. So just going back to this slide, if you think of many of these issues, if we embed this practice and this pathway into our practice of care, it will get rid of a lot of these issues. It will ensure that we have a differential diagnosis. It will ensure that the ABPI is the heart of everything that we're doing. It will help in terms of the shift of the healthcare provision. Nobody's going to give us any nurses anytime soon, I can promise you that one. But what I can say is that we need to embrace what we can be doing in terms of compression. How are we using our unregistered or healthcare support staff? How can we get them more involved in compression? And the use of compression hosiery kits first line is a way that we're able to do this. And this pathway certainly will eliminate the inconsistencies in terms of bandage selection. So what's the impact? Well, we've certainly seen an improvement locally. We are seeing an increased recognition of ulceration. We've got improved clear diagnosis. That can only be a good thing. We have got an optimum use of compression, and hallelujah, we're taking into account that important aspects in terms of edema management. We are using hosiery kits first line, and we're getting the connection of those patients with that hosiery kit and that healing. And we know if you look at the Venus 4 trial, less patients recurred in compression hosiery compared to compression bandaging. And I think that's because you've brain trained your patients that this compression system, in terms of a stocking, has healed your leg ulcer. So they're much more likely to continue with that. And we are certainly seeing improved healing rates. So to summarise, this pathway will help to improve your healing rates. As such, it will help to improve your patient's quality of life, and it's got a massive impact in terms of your caseload management. The increased use of hosiery kits, because they're not practitioner dependent and they're extremely quick, will release some time to care. It will ensure that your non-registered HCA support services are involved in that care like they should be, and it will give those patients those options to self-care. So join me in the leg ulcer revolution. Release your time to care. Thank you.